If you're tackling complex medical concepts, whether it's for a high-stakes exam or, just be really well informed, the sheer volume of information can be overwhelming.
It really can.
Welcome to the deep dive. Today we're taking on some high-yield pathology concepts, pulling from a really solid review guide. We're not just reading a textbook here, we're synthesizing the facts that actually connect and stick with you.
And that's exactly our mission. We're here to act as your guides, to pull out the most complex, the most essential concepts across all the major organ systems. We're talking vascular failure, renal diagnostics, endocrine disorders.
The big stuff.
The big stuff. The goal is for you to walk away with not just definitions, but real applicable knowledge, connecting the facts to the clinical picture.
So we're going on a system-by-system tour. Let's jump right in with the circulatory system, specifically how vessels fail under pressure and inflammation.
Okay, so let's start with arteriosclerosis, which is really just the umbrella term for hardening and thickening of arteries. But the key distinction we need to make is within that.
Arteriosclerosis, the small vessels.
Exactly, the arterioles. And this is critical for understanding things like hypertension and diabetes. There are two main types to know.
All right, let's unpack them. They sound similar, but I know their causes and what they look like under a microscope are totally different.
Totally different. First up is hyaline arteriolosclerosis. Hyaline just means glassy, and it's caused by chronic long-term damage.
From what?
Primarily from chronic hypertension, and this is key, diabetes. With diabetes, all that excess sugar leads to something called non-enzymatic glycosylation. Basically, sugar gums up the proteins in the basement membrane.
And that's what we see.
That's what you see. Those proteins deposit in the vessel wall, making it look pink and glassy and, of course, narrowing the lumen. It's chronic, slow damage.
So pink and glassy means long-term trouble, like hyperglycemia. What about the other type?
That would be hyperplastic arteriolosclerosis. This one isn't from a chronic deposit. It's the body's reaction to acute, really severe pressure.
Malignant hypertension.
Right. Malignant hypertension. The intense pressure makes the smooth muscle cells in the vessel wall just multiply. They proliferate, creating layer after layer of muscle.
And that gives you that classic onion skin appearance.
The classic onion skin. And that's the core distinction. Pink protein versus muscular onion layers. It tells you everything about the mechanism.
That's a great way to anchor it. Okay, so from structural failure, let's pivot to inflammation. Vasculitis.
Right. This is when the immune system starts attacking the vessel walls. It's often mediated by what we call type 2 or type 3 hypersensitivity.
So what does that actually mean for the vessel?
Well, simply put, type 3 is when you get these antigen-antibody complexes. Think of it like immune system trash piling up in the vessel wall and causing inflammation. And that damage leads to two big problems. Vascular insufficiency, because blood flow gets blocked, and of course, thrombosis and infarction downstream.
Okay, and we've got two high-yield types to lock down. Let's start with the one that's a big threat to vision.
That's giant cell arteritis, also known as temporal arteritis. It's the most common vasculitis in older adults, and it hits the branches of the carotid artery. So the temporal, facial, and crucially, the ophthalmic artery.
And the clinical picture.
They'll see a headache, maybe some jaw pain when they chew, and a really, really high ESR. That's the erythrocyte sedimentation rate. The urgency here is acute.
Why so urgent?
Because if you don't hit it with corticosteroids immediately, that inflammation can cause irreversible blindness. It's a medical emergency.
Wow. Okay, so the other key one is Berger disease, thromboangiitis obliterans. This one's linked to a very specific lifestyle factor, right?
It absolutely is. It's found almost exclusively in young men who are heavy smokers, very heavy smokers. It's an inflammation of the small and medium-sized arteries in the hands and feet.
Leading to?
Severe peripheral vascular symptoms, claudication, ulcers that just won't heal, and even gangrene. The practical application here is direct. The disease only improves and often stops completely, with total smoking cessation. It's an incredibly strong link.
Okay, before we leave the vessels, a quick check on a couple of malignant tumors and their associations.
Two to remember. First is Kaposi sarcoma. This is caused by human herpes virus 8, or HHV8. We classically see it in immunocompromised patients, like someone with untreated HIV. It shows up as those reddish-purple raised macules on the skin.
And the second?
Angiosarcoma, a really deadly tumor, often found in the liver, and it's directly linked to environmental toxins. Think arsenic, polyvinyl chloride, and an old radioactive contrast agent called thorotrast. Knowing that exposure history can be the key to the diagnosis.
Moving on to the lungs, a concept that I think really confuses people is the AA gradient, the alveolar arterial gradient. What is it and what does it actually tell us?
So the A gradient is just the difference between the oxygen in your alveoli, the A, and the oxygen in your arterial blood, the little a. It's a simple calculation, but it's incredibly powerful because it tells you if a patient's low oxygen is the lung's fault or if it's an external problem.
Okay, so what's the key finding?
An increased A gradient, a wide gap. That tells you the lungs are the problem. Oxygen is getting into the alveoli, but it's not crossing over into the blood properly. Maybe a diffusion problem, a VQ mismatch, or a shunt.
So a high gradient points right at the lungs. What if the patient is hypoxemic, but that gradient is normal?
If we look outside the lungs, a normal A gradient with low oxygen means the gas exchange surface itself is fine. The problem is either the body isn't getting enough oxygen to the lungs, or the brain isn't telling the body to breathe.
So things like a drug overdose depressing the respiratory center.
Exactly. Or a severe upper airway obstruction like croup or epiglottitis or even muscle failure like an ALS. The mechanics of breathing have failed, not the lung tissue itself.
That makes perfect sense. Now, let's talk about a different kind of mechanical failure, aspiration. Where the infection ends up depends entirely on how the patient is positioned.
Yes, this is a fantastic practical point for reading chest x-rays. If a patient aspirates something while lying down flat, supine.
On their back.
Right. The material will tend to settle in the superior segment of the right lower lobe. But if they're sitting up or standing, in the erect position, gravity takes it somewhere else.
To the posterobasal segment of that same right lower lobe.
Precisely. So you always have to consider the patient's position to figure out where that insult happened.
Let's get to the bugs themselves. There are a few key pneumonia pathogens with really unique features we need to know.
Right, you have to go beyond just the gram stain. Take Staph aureus. This one can act as a superantigen. It gives you that productive yellow sputum, and you see it a lot in patients with cystic fibrosis or IV drug users.
Yeah.
It's also famous for causing abscesses that can lead to a tension pneumothorax.
And then there's the one you worry about in the hospital.
Pseudomonas aeruginosa, a total nightmare. It's the most common cause of nosocomial or hospital-acquired pneumonia and the leading cause of death in CF patients. Its calling card is a productive green sputum. That green color comes from a pigment called piocyanin.
What about the ones that cause weird systemic problems?
Legionella is the classic. It loves water, so you find it in cooling towers, ship water, that kind of thing. But here's the synthesis part. It doesn't just mess up the lungs. It can systematically damage the juxtaglomerular cells in the kidney.
The ones that kick off the RAS system.
Exactly. And so you end up with an endocrine failure called hyporeninemic hypolodostronism. Then there's hantavirus. You get it from inhaling deer mouse droppings, and it leads not just to lung problems, but often to full-blown ARDS and renal failure.
Okay, wrapping up the lungs, let's quickly hit the two big lung cancers, squamous cell versus adenocarcinoma.
The key differentiators are location and associations. Squamous cell carcinoma, think male smokers, centrally located near the main airways, often cavitates, and it can produce PTH-related protein, which causes hypercalcemia. Look for keratin pearls on histology.
And adenocarcinoma.
Adeno is kind of the opposite. Less linked to smoking, it's the most common type in women and non-smokers, and it's located out in the periphery of the lung.
Great distinction. Let's move to the kidneys.
The powerhouses. They have 6 core functions we need to remember. They excrete waste, manage acid-base balance, reabsorb essentials, regulate fluid and sodium, produce EPO for red blood cells, and maintain calcium homeostasis by activating vitamin D.
And their main job, filtration, is all about that 3-layer barrier. It filters based on size and charge, and that charge component is so important.
Absolutely crucial. You've got the fenestrated endothelium on the blood side, then the negatively charged glomerular basement membrane, and finally the podocytes on the urine side. That negative charge in the GBM is what repels negatively charged proteins, especially albumin.
So if you lose that charge,
you lose protein. That's the hallmark of so many glomerular diseases.
Okay, let's talk labs. The BUN creatinine ratio. Normal creatinine is around 0.6 to 1.2. When does this ratio become a really important clue?
It becomes a clue when it signals pre-renal azotemia. A normal ratio is usually around 15 or less. When you see a ratio greater than 15, the problem is likely upstream from the kidney.
So pre-renal.
Pre-renal. It's caused by decreased cardiac output, maybe hypovolemia from dehydration or CHF. The kidney senses low flow and tries to compensate by reabsorbing tons of water and sodium. And BUN, or urea, gets reabsorbed right along with it.
But creatinine doesn't.
Well, creatinine is handled a bit differently. It's filtered and even slightly secreted, so it doesn't get reabsorbed like urea does. So the BUN level in the blood shoots up, but the creatinine doesn't as much. That's why the ratio spikes. If you see a BUN of 80 and a creatinine of 4, that ratio of 20 is screaming that the kidney is thirsty.
That's a fantastic explanation. So what if the damage is actually in the kidney, in the tubules themselves?
That's when we talk about acute tubular necrosis, or ATN. It's the most common intrinsic cause of acute renal failure in the U.S., usually from ischemia or toxins. The tubular cells literally die and slew off.
And there's a key finding in the urine.
A huge one. During the oliguric phase, you'll see these dirty brown granular casts in the urine sediment. You have to picture them. They're literally clumps of dead, damaged epithelial cells. Seeing those is basically diagnostic for ATN.
Okay, finally for the kidney, let's talk stones. Most are just calcium oxalate or phosphate. They're radiopaque, linked to hypercalcemia. But what are the two other special types we need to know?
The first one points directly to an infection, the Staghorn calculi. They're the second most common type, made of magnesium, ammonium, and phosphate. They are also radiopaque, and they only form in alkaline urine.
And that alkalinity is caused by bacteria.
Yep. Specifically, ammonia-producing bacteria like Proteus or Staph, and these stones can get so big they fill the whole renal pelvis, taking on the shape of a stag's horns.
And what about the rare one you can't see on an X-ray?
That would be the cystine stone. They're radiolucent. It's from a genetic defect where the kidney can't properly reabsorb the amino acid cysteine.
Okay, shifting gears to endocrine. The adrenal steroid pathway is a nightmare to memorize, but there's one high-yield deficiency in congenital adrenal hyperplasia, or CAH, that covers 90% of cases.
Yes, the 21-beta-hydroxylase deficiency. The best way to think about this is like a highway. The steroid pathway has 3 main exits, one for aldosterone, one for cortisol, and one for androgens.
Okay.
The 21-hydroxylase enzyme is like a gatekeeper for the aldosterone and cortisol exits. When that enzyme is blocked, all the precursor molecules pile up, and they get shunted down the only open road.
The androgen exit.
The androgen exit. So you get a massive surge of androgens. In female infants, this causes virilization, and just as importantly, since they aren't making aldosterone or cortisol, they can present with life-threatening salt wasting.
So low sodium, high potassium, low blood pressure.
Exactly. And the treatment is just replacing what the body can't make, glucocorticoids and mineralocorticoids.
Moving to diabetes, let's contrast type I and type 2 using the key lab marker, C-peptide.
C-peptide is everything here. Type I diabetes is an absolute deficiency of insulin. These patients are usually normal weight, they can present in DKA, and it's an autoimmune destruction of beta cells. So their C-peptide levels, which are a byproduct of insulin production, are basically 0.
They just don't make any insulin.
None. Whereas type 2 is a resistance problem. These patients are typically overweight, they might present in HNKC, and their tissues are just ignoring the insulin. The pancreas is still trying to pump it out, so their C-peptide levels are often normal or even high.
And under the microscope, type 2 has that amyloid deposition in the beta cells.
The very unique finding, yes.
The long-term damage from high blood sugar is just devastating. Let's start with the nerves.
Diabetic neuropathy. It's the most common chronic complication. It's a sensoromotor, distal, symmetric polyneuropathy. The scary part is it's often asymptomatic. Patients lose sensation in a stocking glove pattern without even realizing it, which is why they are at such high risk for those deep neuropathic ulcers.
And there are a couple of really distinctive skin findings too, right?
Absolutely. The big one is acanthosis nigricans. Those are the dark, velvety plaques you see in the armpits or on the neck. It's a direct visual sign of severe insulin resistance. We also look for something called necrobiosis lipoidica, which are these oval lesions on the shins.
Let's quickly hit some key points in reproductive and musculoskeletal pathology, starting with the female reproductive system and cervical cancer precursors.
Okay, so cervical intraepithelial neoplasia, or CIN, is strongly linked to high-risk HPV types, especially 16 and 18. You have CIN I, 2, and 3, which represent increasing levels of dysplasia.
And CIN3 is basically cancer in situ.
Correct. Full-thickness dysplasia. But the key takeaway here is the timeline. The progression from CINI to invasive cancer takes, on average, about 10 years. That gives us a huge window for screening and prevention.
Now, in the ovary, we have polycystic ovary syndrome, or PCOS. It's a major cause of virilization and also a cancer risk factor.
PCOS is all about endocrine imbalance. You get increased LH synthesis and decreased FSH, leading to an LH to FSH ratio of over 2. This hormonal environment promotes excess androgen synthesis by the ovaries, causing hirsutism.
And the cancer link.
It's subtle but critical. Those androgens get converted to estrogen in peripheral fat cells. This leads to chronic, unopposed estrogen stimulation of the endometrium, which dramatically increases the risk for endometrial carcinoma.
Moving to male pathology, the classic BPH versus prostate cancer distinction.
So benign prostatic hyperplasia, BPH, is driven by DHT. It happens in the central transitional zones of the prostate, and this is critical. It has absolutely no link to an increased risk of cancer.
Whereas prostate carcinoma is a different beast.
A different beast in a different location. It's usually an adenocarcinoma in the peripheral zone. Both can elevate PSA and acid phosphatase, but the lab that tells you the cancer has spread is an elevated alkaline phosphatase that strongly suggests bony mets, usually to the lumbar spine.
Okay, testicular tumors. Two very different germ cell tumors to know.
We differentiate them based on age and tumor markers. Seminoma is the most common germ cell tumor overall. It's very radiosensitive and stays localized for a long time. It might elevate HCG a little bit.
And the other one?
Yolk sac tumor. This is the most common one in children. The key differentiators are an elevated AFP alpha fetoprotein and the pathognomonic finding of Schiller-Duvall bodies.
Which look like tiny glomeruli.
Exactly. That visual is incredibly high yield.
All right, let's wrap up with 3 memorable anchors in musculoskeletal and CNS pathology. First, the brittle bone disease with the cool eye finding.
That's osteogenesis imperfecta, brittle bone disease. It's an autosomal dominant condition from defective type I collagen. And the classic finding you need to remember is the blue sclera.
Why boo?
It's the reflection of the underlying choroidal vein, which you can see because the scleral collagen is so thin and compromised.
And the X-ray sign for the aggressive bone cancer? Osteosarcoma.
For osteosarcoma, a malignant bone tumor we often see in teenagers, you look for the Codman triangle on an X-ray. It's the shadow you see when the fast-growing tumor literally lifts the periosteum off the bone.
Finally, let's talk about that spinal cord lesion with the very dramatic presentation.
Syringomyelia. This is where the central canal of the spinal cord enlarges, creating a cavity or a syrinx. It damages the anterior white commissure, which is the exact spot where pain and temperature fibers cross over.
So what does that do to the patient?
Because the lesion starts in the center and expands outwards, the classic symptom is a bilateral, cape-like loss of pain and temperature sensation across the upper extremities. But their sense of touch and vibration, which run in different tracks, are preserved until later.
And just to tie back to our first topic, vascular failure, the classic symptom of a ruptured aneurysm.
Saccular or Berry aneurysms are common to anterior circulation. When one of those ruptures, it causes a subarachnoid hemorrhage, and the patient will describe almost universally the worst headache I've ever had.
That phrase is the diagnostic cue.
Immediate blinding pain. That history is everything.
Wow. We just covered a huge amount of ground, from the microscopic, pink and glassy versus onion skin, all the way to complex diagnostics in the kidney.
And that's really the whole point. This level of synthesis connecting the cellular look to the systemic presentation to the lab findings, that's what turns memorized facts into real usable knowledge.
I think the biggest takeaway is recognizing those subtle but really specific distinctions. Knowing why a BUN to creatinine ratio of 20 means pre-renal, or what Schiller-Duvall bodies or dirty brown casts actually are.
Those are the details that stick with you and make a difference. So to test that ability to connect the dots, I have one last question for you.
Right, hit me with the synthesis challenge.
Okay. If a 70-year-old male presents with new onset left flank pain, hematuria, and a BUN creatinine ratio of 25, which finding is most suspicious for a pre-renal cause? And what specific infection should we immediately rule out if imaging reveals a large staghorn calculus?
Okay. That ratio of 25, well over 15, immediately points to a pre-renal cause. The kidney itself is fine, but the flow to it is compromised, so maybe hypovolemia or low cardiac output.
Good. And the stone.
And if we see that staghorn calculus, we have to immediately suspect a UTI with a pneumonia-producing organism.
Like most likely Podius or maybe staph.
Excellent synthesis. That's exactly how you should be thinking. Keep practicing those connections across systems.
Until the next deep dive, keep learning and keep synthesizing.